Well, thank you. I'm very honored to start off this symposium. It's a subject that really is dear to my heart. My whole career really has been a mixture of the two, and I feel truly privileged to be able to have had a career like this where I could switch back and forth from clinical medicine to research. My wife often jokes about it that I feel I shouldn't probably be even paid for what I do because I enjoy it so much. And so I feel very attached to this subject. This is going to be a philosophical discussion. It's not a scientific one, even though we're going to be talking about science. And I want to make this more of a personal type talk. So I need to start off with jargon, because I know when I was a medical student, I never would have predicted I would end up in a career that I have. I always thought I wanted to have, quote, an academic position. I wasn't sure if that was more because I wanted the name on the end of it, or whether I really like the academic side. And I realized I really do enjoy the academic side. So some jargon issues that come up, which I did not understand when I first started out. So a researcher or a medical scientist, a clinician versus clinician scientist, non-academic, academic. This is becoming a bigger issue today as medical schools are really de-emphasizing the science curriculum. I know, unfortunately, in my own institution, I sit on a basic science committee trying to make sure that it survives in our school, but it really has been drastically reduced in our curriculum, much to the chagrin of many of us. So this town gown, this is something I experienced as a medical student and didn't really know what I wanted to be, what my identity would be. So the two stereotypes, these are broad categories, but unfortunately they have implications for how you are treated. So there's the clinician, strong clinical skills, great diagnostician, doesn't know a lot of science, but is able to communicate with patients and works away with them. What fits your busy schedule better, exercising 1 hour a day or being dead 24 hours? And then there's the clinician scientist. So good scientific knowledge, spending a lot of time doing research, writing grants and papers, but the attitude from the clinicians often is, oh, this person should not be left alone with patients. Maybe they come from the Center for Study of Phenomena that it keeps scientists scratching their heads. So clinician scientists, though, bring a critical eye to the bedside. If you think back through most of the 20th century, there was really not much distinction between clinicians and scientists because medicine was evolving so much. We didn't really have the, quote, evidence-based medicine with all the guidelines and other things that you have. It was more of an ongoing learning solution, going way back to people like Banting at Best at my home university in Toronto, where I trained with the discovery of insulin. One of the ones, an example I'm going to bring up is mistense. I do this because when I was young, I think my mother conditioned me from the time I was born to be a doctor, but these mistense scared the daylights out of me for actually being around patients and being sick. So these were for cystic fibrosis, and they had these oxygen tents, and the logic was these poor kids have problems with air, and rather than having a mask on that would suffocate them, you'd have this whole tent so they'd live in this high oxygen environment and they'd have a higher FiO2. And this was actually on the posters for the Cystic Fibrosis Society. It was one of the major ways that they got money. So people began to question the value of these, and the issue came up, is it ethical to test the role of these mistents? So there was this paper in Pediatrics in 1972 where they addressed this. So in this example, the physicians understood the physics of gases, and they realized that carbon dioxide is heavier than oxygen. So it would actually settle to the bottom of the tent, displace oxygen, and make the children potentially worse. So there was a huge battle. You can't study this because it'd be unethical. Plus, there was the poster, as I said, for the Cystic Fibrosis Society. So here's the data from that study, and you can see that the oxygen consumption and the effect on airway flow rates was higher in all the patients without the tent. In fact, you've never seen one of these. You've never had to worry about them. But as a kid, I was always worried, oh, please don't let that happen to me. So they were actually worse. So these were clinicians using the science at the bedside, beginning to think about the processes and correcting a terrible error. Now, an important issue is how we think as doctors and scientists. So the cognitive science analysis of medical reasoning, so somebody I worked with in the past, Vimla Patel, and this Kazir, another person, an expert in this area, they describe domains of knowledge. And we have two domains. We have a basic science domain, and we have a clinical domain. So that may be a little disconcerting for this session. These really are two different sections of your brain. So what is a domain? A domain is a collection of facts and experiences that allow you to rapidly process things. So the knowledge levels in scientific reasonings are like so. First, there's definitions. Cardiac output is heart rate times stroke volume. Preload is blah, blah, blah. Afterload is. Those are simple definitions. The second level uses concepts that build on that. So once you have a definition of cardiac output, preload, and afterload, you could say cardiac function are preload, afterload contractility, and heart rate dependent. The third level is where it really gets serious, and those are complex concepts. So now you say there's a clot in a pulmonary artery, it blocks the circulation. What are all the consequences? So to answer that, you have to know the definitions, you have to know what determines cardiac output, and you have to know the whole scenario of the whole circulation. So this requires building up experiences in the domain of the expertise, and this is true both in clinical medicine and research activity. And both these, you collect these definitions, the next level, and process them higher. And a good example is the chess player, where they say to be an expert, you need about 1,000 hours to master it. So it's the same way with clinical medicine. You need to have that experience. That's what a residency or training program is all about, is building those experiences. But it's also true in the science side, that you have to build up that time doing things, failing a lot of times, succeeding at others, to build up those experiences. Now, a big part of the way we think is called adductive reasoning. It's a form of logical reasoning that goes from observations to a theory which accounts for the observations, ideally seeking to find the simplest and most likely explanation. It's an inference to the best conclusion. Now, unlike deductive reasoning, the premise does not guarantee the conclusion. You got to have an experience component to it. So here's a simple example. The grass is wet. Well, most likely it rained last night, and that would be your first impression. However, it could also be the sprinkler was on, or both. So the key point here is the simplest and most likely. And this is really a fine balance, both in clinical medicine and in research. You do want to go to the more obvious one, but you got to be careful and say, wait, was there a sprinkler there, or just let that affect you? But it's much faster and more efficient. And I find clinically, too often, on the clinical side, people sort of don't look at the simplest, and they get lost in some of the, oh, maybe it was the sprinkler, and let me go find the sprinkler, and waste a lot of time and don't take care of the patient. So there's another part of this, is you can think forwards and backwards. Years ago, one of the studies I did with Dr. Patel was we gave questions to expert and novices. So for example, the person has retrosternal crushing chest pain going down the left arm brought on by exertion. Even first-year medical students start thinking of coronary artery disease or angina. But then it goes straight through to the back. And all of you are seasoned enough to know, oof, I got to think about something else. Or it's worse when I take a deep breath. So other things begin to qualify it. So both on your clinical side and the science side, there's these things that don't quite fit that you've got to start putting into your thought process. Now, a key point is the science domain and clinical domain can talk to each other, but they both have to be well formed before you can do that. They have to get to that upper level. And that's the tricky part in education, because if you start by just teaching the science, a lot of it doesn't work that well because you don't have the clinical models to help put it in place. But if you just start with the clinical, you don't have the science part to understand some of the basics. And to me, that's one of the real challenge in education, is how you mix these two, because they are separate, and you really have to have them well developed before you can use them properly. Now, Karl Popper is an important character in understanding reasoning. He rejected the classical views on inductive reasoning. Inductive meaning A implies B, implies C, implies D. And his approach to science was empiric falsification. So a theory in the empiric sciences can never be proven, but you can falsify it. In fact, that's what we do at the bedside. So science may be described as the art of systematic oversimplification. Whenever a theory appears to you as the only possible one, take this as a sign that you have neither understood the theory nor the problem which it was intended to solve. But the issue is that the bedside is a much faster way to think and reason, but you always got to be checking yourself. Do all the facts fit? So whether you're doing science or whether you're at the bedside, are there contradictions in what you're seeing? In that case, start reprocessing it. So I think this should be the model for all clinician scientists and for all clinicians. So do clinicians actually need medical knowledge? Most of medical practice, I must admit, is actually at the brainstem level. I mean, I love the science part. I play with this at the bedside all the time, but most of what I do, frankly, it's brainstem. I did this last time and he died. I won't do it again. I did this last time and he got better. I'll do it again. But even using the wrong scientific models can be a useful memory tool. For example, in my area, the classic cardiac function curve with this marked plateau, no downward part to a Starling curve, giving more volume doesn't increase output. But what can happen with excess volume? The cardiac function can decrease. It looks like there's a downward part. So even if you had the wrong theory, which they don't really exist, the curves are changing, but it looks like that, it would actually be useful because you would actually know that fact with the wrong theory. So it looks like a downward part, but it's just changing curves. Now, as I said, a lot of medical reasoning is done at a brainstem level. So the hypothetical deductive reasoning is far too slow. It's like typing. I mean, if you had to think about each letter as you do it, you can't, versus just if you know how to type properly, your fingers just go and they do it in batches. But again, you have to know when things don't fit and when to back off. So we really deal more with associations. This goes with that. The implication is we learn by experience, and the more experience, the better. Experience during being on call is essential. But this is also true for scientific reasoning. The more studies you do, the more experience you get with studies, reviewing studies, following current advances, that too trains your brain in a thought process which becomes very important. And it requires time and work the same way as your clinical training requires time and work. So basic science in the ICU clinician, whereas 95% of practice may be at the brainstem level, in the ICU we're frequently exposed to that 5% that requires new reasoning. And this is where if you have some of that background, it can be really helpful. It gives you a deeper understanding of how things work. It helps understand physiological limits. For example, does a football player or hockey player work out why do they work out in the gym rather than just play games? Different parts, different conditioning, which can help you for that process of playing the game. So having that scientific part can actually help you at the bedside as a physician. So the types of research for the clinician could be very basic: in vitro, cell culture, genetics, biochemistry, organ, whole organ, systems biology, animals, humans, applied physiology, or clinical investigations, observational clinical trials, outcome studies, quality assurance. So there's different levels, and each one of these has its own set of knowledge base and patterns. Basic research, the thing about basic research, and why I have enjoyed having that as part of my career, it gives you that deep insight into how the body works. I mean, that to me as a physician is one of the things that I love the most. I've been privileged to sort of study this very advanced thing, human beings, which are incredibly complicated, and nature by its diseases just does the experiments for me to see how this thing actually works and keep modifying my thoughts over time. So, and what is possible in the system. So research during training versus research post-training. Research during training, well, the important part of it, and this is why I encourage my trainees in the past to try to do some research, is you learn how hard it is even to obtain garbage. Now you read that paper, that was junk. Yeah, you try and collect that junk. It's not so easy. So you become more sympathetic to what you read. But you also learn how easy it is to convert noise into a message. Oh yeah, I just put this here and graph it this way. So it teaches you a healthy skepticism, but it also teaches you a respect of what it is to gather stuff. And I think it's important to have both sides of that. It teaches you to check for errors in data collection, and you'll hear about some of that today. Choosing appropriate statistical techniques, which subjects, so we're going to be hearing about all this. But a key point is not to overstate the results. and only exclude things based on the consistent and well-defined principles. So you really want to make sure there's an intellectual honesty in what you do as you think. But if you just stick with everything, you just confuse the message. But you do have to learn how to actually not eliminate things and basically cheating. Okay, so it helps you evaluate the medical literature was a lifetime task for all of us. So research during training versus post-training, it's pretty primitive because, as I said, you need to build up experience, and this must be a clinical fellow you're sort of destroying the lab. So it does take time to develop these skills, and you should not expect them to come right away. But prior laboratory experience helps you to see physiological insights. So, for example, my experience with discussing the importance of transmural pressure at the bedside came out of a lot of animal studies that I did in the past and helped me a lot. Research for the practicing clinician, I think this is almost, in my unit, I consider it a moral obligation. You don't have to actually do it, but I want you to be taking part. I mean, you don't have to run your own project, but you should be taking part in other ones that are going on. This helps validate what we know, help maintains intellectual honesty. And as I said, you don't have to run the study, but you need to be willing to take part and be respectful to the intellectual process. I think that is an essential part. It validates what we know. There's no absolutes. Nothing is permanent. And in my own career, I could give a whole talk on that, how dramatically things have changed from the beginning of my career to now. It's just amazing. As Karl Marx said, all that is solid melts into air. So practice must always be reevaluated. We should never, never be taking things as a given. Look at some of these. Tight sugar, activated protein C, the anesthesia, ABCs, heavy sedation, all gone. In my own experience, I did a lot of work with nitric oxide for a while in animal studies. I was studying pigs rather than rats or mice. That turned out to be extremely useful for me because pigs do not produce much NO. So all the work in rats and mice was meaningless in pigs and probably meaningless in humans too for most of the studies. So based on my animal studies, I never would have entered the NOS trials in humans because I could see they were going to be damaging, which they were. Same thing, I did work on reactive oxygen species in my career. This was a translational piece I wrote. One of the things I learned from that is to think about scavenging a single superoxide molecule, again, is an incredibly naive concept. You want to modulate but not obliterate. But these were concepts that I learned from doing my own animal studies. So it didn't surprise me that these studies would fail when they were done because they were based on a very naive approach with clinicians who really hadn't thought through the science. I'm going to skip this, I think, for the sake of time. Well, there are limits to science, too. One of the comments I like is physiology predicts nothing but explains everything. When I actually prepared this talk the first time, I went searching for the source of this quote because I got it from one of my mentors. So I tried to find it. I did find it on the internet, and I went to the site and I looked at who it was referenced, and they actually referenced me. Now, I know it's not mine. I got it from somebody else, but this site here, which has a bunch of quotes, had my name on it, but it's not mine. However, a research career is not for everyone. I think you have to be a little crazy to want to do the research side in the clinical. It's a lot of extra work, a lot of time spent that is not remunerative, and it's not funded like clinical work. And you're exposed to constant criticism from granting agencies and journal reviewers. So that really is a pain. And clinical management can provide much more immediate gratification, at least when successful. But actually, when you're getting into one of those messy situations and all your patients seem to be dying on you, it's nice to actually go back to the laboratory to get a little escape from the patient side. And that's what I've enjoyed in my career, is to be able to go back and forth. So again, when I get beaten up by the journals, it's time to go back and be a doctor. And then losing on these patients, it's time to go back and play in the laboratory. And it's nice to be able to switch back and forth. However, for those who are crazy enough, it can be very stimulating. I think it's very important for helping avoiding burnout, and makes you feel much more intellectually credible. I don't think I could actually talk about a lot of the things I was doing if I didn't actually try doing some of them myself. And it keeps you much more intellectually rigorous with a healthy mixture of skepticism and optimism. One of the great things is this: you develop national and international colleagues, which is an incredible privilege to be around the world and meet people with a common language. We may speak different tongues, but we have a common language, which is our scientific basis. And the reverse side of the story, clinical experience for the scientists, when specific basic science information is provided to medical students prior to solving a clinical case, they are unable to use this information. Wait, which way did I go here? Yeah, if you just gave it to them before, they can't really use it. But once they get experience, then they actually can. And I'm going to skip that for the sake of time. So clinical experience for me is essential for the clinician science involved in clinical studies. We're going to talk about endpoints. You can't really talk about endpoints if you haven't actually seen patients and understand what happens to them. It's key for understanding inclusion and exclusion criteria. Are the conclusions true outside the study? If you're looking at, for example, the use of colloids versus crystalloids, if you understand some of the background side, it would help you. In this case, is it the same for perioperative patients versus septic patients? You could begin to ask those type of questions if you actually have that clinical experience. And then you can also ask, is your clinical experience, the clinical experience in the trial, the same as in your own institution, and should you be applying it in your own institution? So will the clinician scientist be able to survive? That's a good question, because it's becoming much harder to get funding. The experience required is more. The training is becoming longer because it's getting much more sophisticated. So I think it is an endangered species. So in conclusion, clinical research was once at the core of activities of early 20th century clinicians. The complexity of modern science as well as clinical medicine has separated these two domains, so it's now difficult to do both because the science part, especially the trials part, has become so much more sophisticated. The clinician scientist is an endangered species. The rewards to do both are diminished. It's harder for clinicians to get funding for basic and innovative ideas. It's difficult to compete with the full-time professional researcher. Yet the bedside clinician is an essential link in providing the validity to the system. So we must work to maintain a scientific basis for clinical practice, starting from medical school and continuing through professional development. It's not about clinical practice, but about maintaining intellectual integrity. And the subtle reasoning that comes from scientific knowledge and the judgment that is based on this knowledge is what distinguishes us from machines that would otherwise replace us. So I don't think if we had that part, just put the robot in and let the robot do the job for us. Be cheaper. Thanks.